Well, welcome everybody. For me, it's an honor to be able to present you with this webinar. Thanks to Dr. Miller. Dr. Miller is I consider him a good friend, and but fundamentally he's a wonderful, wonderful professional. Affectionately, I call him Encyclopedia Implantica, because his knowledge would fill Encyclopedia Britannica on his own. He received his BA from New York University and his master's from Hofstra University, both in biology. He graduated with honors from New York University College of Dentistry back in 1981, where he received the International College of Dentists Award for Clinical Excellence, and then completed his residency at Flushing Medical Center in New York City. Dr. Miller is a fellow American College of Dentists board certified diplomat of the American Board of Oral Implantology, honored fellow of the American Academy of Implant Dentistry, diplomat International Congress of Oral Implantologists, fellow Academy of Osseointegration, and is the acting chairman of the Department of Oral Implantology at the Atlantic Coast Dental Research Clinic in Palm Beach, Florida. He is director of the Center for Advanced Aesthetic and Implant Dentistry in Delray Beach, Florida, and co-director of the Pacific Institute for Advanced Dental Education. He also has a full-time practice dedicated to implant dentistry and revision surgery, and has an active international lecture schedule, as well as being engaged in biomaterial, laser, and implant research. Well, I'm afraid, Dr. Miller, there's something that's wrong with your biography here.
What's that?
The international lecture schedule is kind of beat up lately.
Yeah, it certainly has. In fact, in the past 2 months, I've had 8 conferences cancel on me. So where we could, we did this on the web in this format. But you know, with my lecture style, the interactive lecture style that I have, I love that repartee. I love that you know, question and answer kind of thing, and I really feed off of the interaction with an audience, and that's missing in a format like this. So what I'd like to do as we move forward, if any of the participants have a question, just post the question immediately. Don't wait until the end of this thing, because I'd like to have it within the context of what I'm talking about. So if you have any questions, just interrupt me. And Vic, if you see a question pop up and it's a good point that needs answering, just interrupt me immediately. Okay.
Do it that way, and we'll get started. And welcome everybody once again, and thank you very much, Dr. Miller.
All right. All right, everybody, let's get started. I understand that from Victor that there are participants from many different countries, many different continents as well. So I'm happy to do this. I've done about 5 or 6 webinars now in the past few weeks, including 2, which were the American Academy of Implant Dentistry maxi courses. And those are 8-hour lectures. And I will tell you that 8 hours talking in front of a computer is a very different experience for me. And that's why I mentioned that I really prefer the in-person format, but for the time being, this is our world. It's a virtual world, and you can't stop the dissemination of information and knowledge. So I'm happy to do this for Victor and share this. Now, I know there's probably a number of people who are listening right now who have heard me lecture before. And probably some similar topics to this. And one of the things that you'll know about me is, number one, I've never given the same lecture twice, and I don't intend to do that now. So I take this responsibility very seriously. I love sharing this information with you, especially because I'm a full-time practicing clinician. Aside from the academic positions that I hold and the research that we do, I still work a full-time implant practice. And I'm going to share with you some of the cases that we've done just in the past week or two, because I shoot a lot of 4K video through my surgical microscope, and it really helps me in what we call case-based learning. And again, for those of you who have seen me before, you know that I like a healthy dose of science and biology, but I decided to do something a little bit different today. And since I don't want the biology to get in the way of clinical skills, because that's really what people most often are looking for in this, I decided to take a completely different path for this lecture and make it case-based learning, case-focused. I will talk about the science biology, but I won't make the majority of the lecture in the scientific part. So when we talk about the concept of composite grafts, what do we mean by composite? It's not composite like you put in a tooth. A composite graft means that you're using more than one material and you're putting it together to make a new type of regenerative material. Now, it can be different kind of graft materials. It can be the use of growth factors. It can be the use of fibrin. It can be combined with membranes, both resorbable and non-resorbable. But the whole object is to regenerate a site that allows us to get the best clinical outcome, regardless of what your end is. If you're placing an implant, well, we want to regenerate not just as much volume, of appropriate volume that we can, but to regenerate the best quality of bone. And that way we get a higher percentage of implant success, fewer problems with peri-implantitis. And I'll explain a little bit about that. As we go through each case, I'll explain what my rationale is, because it's not just one material. It's not just one way of doing things. It's a very, very biologically based decision-making process, depending on the site. And if you've ever taken a course, if you've ever listened to a webinar on the role of socket grafting, I mean, this is almost ad nauseum for me. The maintenance of ridge volume, bone density, bone trajectory, preventing epithelialization into the site after an extraction defect, and then also allows the conversion of the biomaterial to bone. Or if we're not going to place an implant, to get what we call repair, not necessarily regeneration. Repair means restoring the volume of a ridge. And I'll give you an example. If my final goal is even non-implant related, if my final goal is a bridge with pontics, you'll know that you've all seen cases where there's been bone resorption, ridge change, ridge resorption underneath the pontic area. And when you get that, then suddenly you have food impaction, and then you get a very slow, steady drip by drip, either periodontitis, or if it's implants, peri-implantitis, because of food impaction and something like that. So the way I treat my edentulous areas, where I will not be placing implants, or the way I treat my ridges under the intaglio surface of a hybrid restoration, is very different from the sites where I'm going to be placing my implants. And if we look at this to be almost the imprimatur of what we've been doing for decades, not just years, but decades, which is a particulate graft material that we hydrate either with saline or venous blood, and then we take that particulate, we take it to the site, and we place it into the defect, and then we compact it down. And after we've done so, then we have to cover it with some kind of protective device, either resorbable or non-resorbable membrane. And I'm sure that virtually everyone in the audience has done this. This is the way we graft. We've been grafting for not just years, but for decades. But if we have a complication with something like this, what are the potential complications? Well, one, of course, is premature dehiscence of a flap, or in this case, if we're covering with a collagen membrane and not getting primary closure, premature loosening or loss of a membrane, which allows extravasation of the graft material, and then we get salivary contamination. of our grafted site. So we lose volume, we lose the quality of bone that we need at the surface. Deeper down within that, we might get a good quality of bone, but we'll lose several millimeters and sometimes even more than that at the crest, when these things they hiss prematurely. It's a little technique sensitive, but if we do it and we do it well, that's fine, and we get actually a good result. But if you're like me, just because we have success in something doesn't mean that we have 100% success, nor does it mean I'm not looking to do better, whether it's the quality of bone, the quantity of bone, the size of the ridge, the percentage of vital bone that we get. And I'm looking to get a better clinical outcome. And I'm also looking to make my paradigm a little bit easier. Fewer complications, fewer post-op sequelae, less pain post-operatively, less incidence of infection post-operatively, better ridge repair and ridge regeneration in these cases. So it requires attention to detail, whether it's for the graft material itself, whether it's for the type of membrane that you use and its placement, whether it's the suture technique that you use, the type of suture, type of membrane, the oral environment, what do we do to protect this? Every one of those parts is essential in getting a successful clinical outcome in these cases, and ultimately going on to placing implants if that is your final surgical and prosthetic goal. And when we select a graft material, I'm not going to talk about so much the different types of graft materials, which of course are xenograft, allograft, alloplast, autograft. That's less important to me. It's not where the graft comes from. It's the way it functions, the way it responds, what it gives us in the end. And I start with resorbable versus non-resorbable. Now, if the goal that you have is to place an implant, why would you use a non-resorbable graft material? Because after all, implants do not integrate to graft material, they integrate to vital bone. So if you're using a non-resorbable material and that resorbable material stays there and you end up with a very low percentage of vital bone, what is it that you're accomplishing? Because if you have a peri-implantitis, if you have a complication or even a failure, an outright failure of an implant that's newly placed, or even one a couple of years later that suddenly comes out without warning, and you want to know what the mode of failure is, very often it's just too low a percentage of vital bone. Stuart Frome, a great periodontist from New York University, wrote a chapter of Ole Jensen's The Sinus Book. Ole Jensen is a oral and maxillofacial surgeon in Denver, Colorado, probably one of the finest oral surgeons in the world. And his latest book has contributions from a lot of these other great clinicians. And Stuart Frome and Steve Wallace actually got together maybe 20 years ago and did a paper on the use of BioOs, a xenograft, a non-resorbable xenograft, in sinuses, and then looked at the survival of those implants in xenograft grafted maxillary sinuses. And their conclusion was that it's as successful as any other material. And if you just go by the abstract, if you read the paper and go by the abstract, you say, well, if it's good enough for them, it's good enough for me. But unfortunately, and I've lectured with Steve Wallace several times through the years, I think it's one of the most flawed papers that is most often quoted and cited in a lecture. And the reason for that is that the real reason BioOs grafted sinuses have successful implants is not the graft material, it's how much vital autogenous bone is at crest. Because after all, the loading area of an implant is the coronal half, coronal third. And if that part of your implant is in bone, you're more likely to have success. And they never did a study where the sinus floor was actually congruent, almost touching the crest, where there was no vital bone. In those cases, I have found that you have a very high degree of failure. So you have to be able to really read the literature and critique it really, really well. Next is dense crystallinity versus low crystallinity. Why should crystallinity have any effect on this? Well, the more dense a particle is, the longer it takes to resorb, the higher the density. And the body responds to crystallinity entirely differently. For example, the lowest crystallinity, or even what I would consider to be non-crystalline, are the TCPs, or the non-crystalline HAs, which would be something like Osteogenic, or a non-crystalline tricalcium phosphate like Curasan's Resorption. And the dense crystallinities would be cortical bone, or worse, they would be xenografts. Now, both are used around the world, and I use both, but I don't use one or the other in every circumstance. There should be a reason why you use a dense crystalline material in one type of case and a low or non-crystalline bone graft material in another case, depending on what your final goal is. Next, resorption time. It's just like a collagen membrane. You can get collagen membranes that will resorb in 2 weeks. You can get collagen membranes that will resorb in 6 to 12 weeks. You can get collagen membranes that resorb in 4 months, or 6 months, or 8 months. Are they appropriate for every single case, regardless of the resorption time? Obviously not. If you have premature resorption after 2 weeks of an area where you have an opening and you expose your graft material, well, that's not a good strategy, as opposed to a collagen membrane that might resorb over 6 months or longer. And the problem is, if you're trying to get contribution of bone growth from the periosteal side, because you actually can get bone growth outside of bone that comes from periosteum, and that is the conversion of undifferentiated periosteal stem cells. So the longer the resorption time of a collagen membrane, the less contribution you have three-dimensionally from the periosteal side. As opposed to graft material, if you're going to place an implant and want the highest percentage of vital bone, well, you better have a graft that resorbs in the time frame that you want to place your implant. If you're going to wait 4 months, I would hope that a good portion, or maybe the majority of the graft material that you have placed, is resorbed and turned over into host bone, as opposed to a very dense crystalline, non-resorbable material where it's primarily graft material. Okay, it's got to be based on the biology of the material. The percentage of vital bone. When we use non-resorbable graft materials, such as a xenograft, and regardless of the time you re-enter, it could be 4 months, 5 months, 6 months, 8 months, and it's primarily graft material. The reason implants tend to have more complications and tend to fail more easily in those regenerated ridges, and this comes from Stuart Frome's chapter in Ole Jensen's sinus book. The histomorphometry of xenografts is you get a maximum of 25% vital bone, 25% is residual graft material, but 50% is not bone, it's connective tissue. So I'm going to show you some failures of cases where the mode of failure, the reason they fail, is that it's not bone, it's primarily connective tissue. So the percentage of vital bone is extremely important for us. The type of cellular response is also important. Now, there's 2 ways that graft materials are actually turned over, if they can be turned over. One is called solution-mediated resorption, and that's where a cell releases acidic material, which breaks down, just solubilizes and breaks it down. So a non-crystalline HA or a non-crystalline tricalcium phosphate, just by dropping the pH, will dissociate, will disappear. As opposed to phagocytosis, where the cell comes and actually cleaves a portion of that graft material away and carries away the graft material. The non-ceramic, low crystallinity or non-crystalline materials, they are primarily turned over by solution-mediated resorption, which I prefer. Very dense crystalline, cortical bone, in cortical cancellous bone mixes, and xenografts end up with cell-mediated resorption, which means the cells get together and they realize that they can't by themselves attack a graft particle. What they do is they gang up and they produce another type of cell called a multinucleated giant cell. And the multinucleated giant cell is enormous. And that cell together surrounds a particle and physically cleaves off portions of that and carries it away. That's why people say, well, biowas will resorb. It just takes an extended period of time, sometimes several years, because it takes a long time for these multinucleated giant cells to cleave off pieces and carry it away. The problem is they're not resorbed, they're just transported. They're transported to the lymph nodes, they're transported to the lungs, they're transported to the spleen. And that's why you get decreased immune function in areas where there's a lot of this material being used. And again, when you get a multinucleated giant cell response, what do you get? You don't get bone, you get primarily connective tissue. And that's why in xenograft sites, there's 50% connective tissue. I don't want to be placing my implants in connective tissue. Now, I'll actually show you some videos of implant failures and pain related to connective tissue, not to bone. Next, the quality of bone at time of implant placement. You know, you've all gone into grafted sites and sometimes the bone quality is not that good. It's pretty soft. It's D4 bone or a lot of graft material remains. So what is the quality of bone? Because I want good tracking of my implant. I don't want to strip it out if it's poor quality. And I want every possibility for that bone to integrate to my implant body. And then the percentage of vital bone after integration. Will that graft material, if there's some left, will it continue to resorb and turn over into host bone? Not if you're using a non-resorbable graft material. Now, I'm going to start with this case. And again, what I decided to do here was not so much spend time on the biology and the science of this. I mean, when I have to, I'll just explain it without going through a bunch of biology slides. This is going to be case-based learning. And I'm going to have quite a few of these types of cases to show you the application of all of these concepts. And here's the perfect one to start with. This is actually a virtual implant that I've placed here because I saw the patient after an implant had been removed, after it failed. Now, this is actually, this represents an implant position that failed, not for the first time, but for the second time. This was done by a dentist here in Florida, where he placed an implant and a few weeks later, the implant just extravasated, just came right out. And we've all had that happen. We've all placed implants in bone and looked at it and said, okay, something happened, maybe I overheated the bone. I mean, you come up with all kinds of excuses. And the implant came out and no problem, I'll just re-drill the osteotomy. Maybe I can get a slightly larger diameter implant in and place it again. Well, the patient came to me and said, that night after the dentist placed this implant, I was in excruciating pain. And literally within a day or so, I asked him to take it out. So here's a second implant. And when I saw the patient came in with this presentation. So here is obviously the site where the implant was removed. Now, 50% of my practice here in Delray Beach, Florida, is what we call revision surgery. And I'm seeing a lot of failures, not just from my community, but from all over the state, other states, sometimes internationally, they'll come in. So I've developed a keen sense, so to speak, and a very deep sensitivity to what I call the mode of failure, the reason why you have a complication and the reason why these things fail. So I look at this x-ray, and obviously this this implant back here, this was placed by the dentist who did this surgery. So the dentist obviously has skills. He placed it in a beautiful position, nice curve of SPE here, good restoration, good margins, good crustal adaptation to the implant. So the clinician has good surgical and prosthetic skills. Question is, why did this fail? And why did it fail twice? And why was the patient so much in pain after the second implant was placed? Now let's look at this X-ray closely, because we're going to look not at the site where the implant came out. And you can certainly criticize the position of the implant. The implant probably should have been placed here in the center of the ridge. Fine. But that's not the reason. It wasn't loaded yet. It was just freshly placed. Why did it fail? Why was there so much post-op pain? Now I want you to look at the residual where the tooth was taken out and the area was grafted. So here's the original defect, the original lamina dura of the tooth. Now this graft is 2 years old. And this graft has maintained its volume, just a tiny little dip here in the center, which really is meaningless to me, because if you place an implant, the implant will be in contact here and here. So this defect means nothing to me. I can place a beautiful implant in its proper axial position. But when we look at this 2 years later, and now we look at the transition between host bone and graft material. Here's original host bone, the interdental bone, which shows beautiful trabeculation, very nice density, very nice medullary space, and I'm sure it has a beautiful microvascularity to it, as opposed to the grafted area 2 years later, which has no trabeculation, no microvascularity. What is this? This is a non-resorbable graft material that's essentially bound together with connective tissue. Now, when you drill an osteotomy into a site like this, and the patient has postoperative pain, the postoperative pain is from the connective tissue. Bone doesn't have any nerve endings. You're not going to feel anything there, but connective tissue does. And that is the mode of failure here. And now we're going to actually look at the reentry of this and show you why. These are shot through my surgical microscope. And you're seeing exactly what I'm seeing when I'm doing my surgery. I thought, well, perhaps there's a little bit of infection in here, but just a little bit of epithelium that had grown down into the osteotomy where the implant was drilled. So now a lot of swelling here. I'm not sure whether it's infected. Certainly a lot of bleeding, a lot of edema. And look at the bleeding from here now, which is really inflammation. Now I'm going to open this up and I'm going to look. Here is the extraction site. This is the osteotomy from the removal of an implant. But next to it, you'll see bone. This is the grafted area, but you see no vascularity from here. There's no vascularity because, ladies and gentlemen, this is not bone. This is residual graft material. Even though you don't see particulate, that's D1 bone. You drill into D1 bone, you're not going to have a very good clinical outcome. And when I see bone like this, I do a trephined core. We send it off for histomorphometry. Look at this. It's like a ceramic. There's no vascularity here. And you wonder why implants won't integrate into something like this. Now I'm going to go back in and I'm actually going to curate out this material. Now deep down, I'm getting particulate material. So while the crest actually looked good inside the ridge, there was nothing but unincorporated, non-resorbed xenograft. So we're going to remove every shred of that graft material. Look at that particulate in there. And that's the reason why the patient was uncomfortable. It's all connective tissue internally. But if I'm going to graft this and later on go back and place an implant, I can't place an implant in its ideal position in D1 bone. What we have to do, we have to physically remove the entire grafted zone. And I don't care how you do it. Want to drill it out? That's fine. I love piezo surgery. It enables me to get in here and section this out and take it out in almost like a block form. And there's, look at that piece. No vascularity. It's just one solid piece like cement. But until I get to bleeding bone, my job is not done. I've got to go through this, and I've got to literally go down into the medullary space. And in a moment, you're going to start to see the blood wells. Now you see it, starting to see it bleed. That's what I want. Before I place my graft material, it has to bleed. Now we can go ahead and put our graft material, but not a non-resorbable graft material. It would be one that not only resorbs, but turns over to the highest quality of bone in the least amount of time. What about handling the graft material? How do we prepare it prior to placement? And you know, through the years, I've lectured a lot on this, from the use of sterile anesthetic solution to saline to venous blood to autologous serum to autologous plasma. There are huge differences in the clinical outcomes that we get depending on how we prepare it and bring it to the site. The transfer, and the transfer can be in particle form if you're using just serum. It can be the use of what we call sticky bone or PRF block by fibrinolizing everything, putting all the particulate together into a fibrin mass and then delivering that whole mass to your surgical site. It can be done through the use of what we call now composite grafts, grafts that are dissimilar materials but already put into a package that allows us to deliver particulate without the particulate extravasating, and then we can hydrate that with the material of our choice. It has to be, you have to have an easy placement within defect, not have to play with it like particulate material does. We have to be able to protect it as well. Do we even need membranes when we place a composite graft? Radiographic analysis. The problem with some graft materials, especially xenografts, is that on the day that you place it and you take a radiograph, that radiograph shows you a very, very dense material. And then that's sort of your hero shot because you see it well compartmentalized. You think, what a great job I just did. Fine. Looks great radiographically. How do you know when that's ready to have an implant placed? Because 6 months later, it's going to look exactly the same. What is your feedback that tells you that that bone is ready to be loaded, that it's just sparing lamellar bone around an implant? You don't, because it never changes. Membranes. Why do we use resorbable versus non-resorbable? I've used both, and I will tell you that I prefer resorbable. And I prefer resorbable because with the non-resorbable PTFEs, you will never get closure of the soft tissue because there's no capacity for those cells to grow across a non-biologic material. I love resorbable because within a very short period of time, it will epithelialize over that and close. I used to use membranes 30 years ago, 25, 30 years ago, but not with growth factors. It would take about 3 to 4 weeks for that to close. Today, when we use autologous biologics, we use autologous serum, or better yet, autologous plasma. I can achieve the same thing within a week that I used to wait 4 weeks for when we were using just collagen membranes without that. That's what I prefer. Resorption time, I discussed that a moment ago. I certainly don't want a membrane that's going to resorb in 2 weeks, especially in a very acidic pH, because within a couple of days, that membrane can simply disappear and expose your graft material. So I want a 6 to 12 week resorption time for something like this, but not beyond. The cellular response. In this case, it's not so much the bone cells, but it's the epithelial cells, so the fibroblasts that need to grow over the top of that. I want it as fast as an epithelialization as possible when we do something like that. That's why I use collagen. It's type 1 bovine collagen, the same as type 1 human collagen. And the problem, of course, is when you use a membrane of any kind. The whole object of using a membrane is to prevent epithelial migration into the particulate. And that's fine. That's what membranes are designed to do. They compartmentalize your graft material, prevent fibroblastic migration down into the particulate, prevent salivary contamination, and the other way, prevent extravasation of the bone graft particles. Great. Membranes do exactly that. But they also do something that's unintended. They preclude, they prevent the contribution from the periosteal side, either profusion of gases and microvascularity, and even worse, they prevent the undifferentiated periosteal stem cells from becoming osteogenic cells and contributing to three-dimensional growth, bone growth occurring from bone growth occurring from periosteum. And we can actually show that in other lectures. Oh, here's one of my favorite pictures that I took from social media. And so I know somewhere along the line, the clinician who actually did this case is going to see me present a picture like this. And I do this not to criticize the clinician, because I want to commend the clinician for doing a beautiful job on this sinus graft. Well compartmentalized, expanded the area into which you can place the apex of your implant. Two beautiful placements of these implants, 3-unit implant supported bridge. The problem is the caption with this photograph was that this was a 7-year post-op film of this sinus graft. So I submit to you, what is this? Is this bone? Doesn't look like bone. This is bone. This is host bone. And if you were to go to the Steve Wallace and Stuart Fromm paper on sinus grafting with xenograft, you would say, well, here's a successful implant survival in a biomass grafted sinus. Yeah, it is. Except that the reason this is successful is this amount of host bone. It has nothing at all to do with where the apex of this implant is. In fact, I'll bet that if you used even a slightly shorter implant here, it would have survived. Use a wider implant, it would have survived. Maybe just an osteotome-assisted sinus lift without a graft material, it would have survived. So for me, when I see a case like this with that much host bone, this is an exercise. This contributes nothing to the survivability and longevity of this implant bridge. But worse, I don't know if any of you who ever had the possibility of re-entering one of these sites to actually see what this material looks like internally. This is a case that was referred to me a few years back. Actually, the bilateral sinus grafts were done by a periodontist. And about 6 or 8 months or so after he did the sinus grafts, he took a CBCT scan and said, you know what, I just don't feel comfortable placing implants. Well, he was certainly correct. And if we look at this now in coronal section, here's coronal section. What's the word I'm searching for? Every potential complication is represented by this cross-sectional tomograph, this coronal section. For example, it appears that no membrane was placed over the sinus window. And when you don't exclude the epithelium, the epithelial cells will actually grow into the sinus graft here bilaterally, causing a defect. That's why we place a membrane, resorbable collagen membrane, PRF membrane, where if you're making oval window, remove the oval window of bone, place the oval window back over this. Anything to occlude the possibility of fibroblasts growing into this site. Second, the clinician never lifted the Schneiderian membrane off the floor of the sinus. So if you were to place, even if this was a successful graft, if you were to place an implant through here, well, this is going to be in sinus right here. And who knows the health of this tissue that's here. It's probably infected. Next, never released and lifted the membrane off of the medial wall of the sinus. When you do a sinus graft, you do an oval window, you go underneath, lift off the crestal part first, go all the way to the medial wall and lift this membrane to this position. Then you place your sinus graft, as he did here. You want that adaptation to the medial wall. Next, there was actually a perforation of the sinus on this side, unlike the well-capsulated portion on this side. And fortunately, he must have mixed it with some kind of material that kept the particles from extravasating into the sinus. Next, there's still pathology present here. And one of the things that we do when we're doing grafting, whether it's sinus grafting or whatever, if we're placing it into a potentially infected site, and I consider any sinus to be an affected site, the primary organism responsible for this is a gram-negative anaerobe. The only antibiotic that's effective at preventing the growth of this in your graft material is metronidazole or Flagyl. So what we do is we have an IV bag of aqueous metronidazole, 5 milligrams per ml. We put a few drops and mix it in with our graft material before placing it. And that Flagyl then prevents the proliferation of your gram-negative anaerobes, and you won't see these kind of big gas bubbles forming post-operatively. Because I'm going to place my implants here, I don't want to place it through a potentially infected sinus graft or touch a fibrous encapsulated graft right here, or place the apex of my implant up into sinus here. Now, if you place your implant into the sinus here, or place your implant into the sinus here, you take a radiograph from the side, you never know that that implant is sitting out in space. The whole implant body could literally be halfway in sinus. And yet you take the radiograph and it looks perfectly within the grafted area. You will never know that. That's why your clinical skills in doing these cases is so important. So this is actually what that material looks like. I was able to go in both sides. I'm doing my classic oval window. This is the upper left. I remove the window, and what do I find inside? Nothing but unincorporated, not non-bone graft material that's left. No vascularity. There's no bleeding here. But what this is a bunch of xenograft held together by connective tissue. You can actually see me peeling away portions, large pieces of this graft material. Now, there's no one watching this webinar right now who expects implants to succeed in material that looks like this. Well, this is what xenograft in a sinus looks like, folks. Remove it completely. Now we go down and lift up the membrane that wasn't lifted prior to that. And then we simply graft it with a new resorbable graft material. And then later on, we can place implants and know we're going to have a success. So your choice of materials is also equally important. And when we use the wrong graft material and we re-enter a site, this was done by another periodontist down here in Florida near Palm Beach. Placed an implant and there was a defect on the facial, placed biowas granules, and what do we have? Nothing but fibrous encapsulated graft material. And if you use a non-resorbable graft material, this is what you can expect. And it's not just that the graft material did not turn over into bone. That's bad enough. But you get a foreign body reaction. You get a multinucleated giant cell, and the giant cell reaction causes the growth of this connective tissue. Look how much more bone has been lost here around that implant as a result of the body trying to get rid of the graft material. Now here I did a corticocancellous block graft to repair this grafted area. We talk now about extraction media implant placement, treatment of the gap, the space between the implant and the actual bone that remains in the osteotomy, because we're placing a round implant in an extraction site that's not round. Well, at the very least, use something that's biologic. Here I'm going to I've extracted the tooth. I'm going to do the last drill. And when I place my implant, obviously there's going to be a defect here on the facial and on the lingual side of this. So use an implant that has good initial stability, put a healing abutment on, place a graft material down inside here. Of course, the graft material is particulate in this case, so it's harder to handle. I want to make sure I'm getting enough down inside here, and then using a resorbable vicryl suture to make sure that there's no cellular contamination. This is a few months later. Look at the beautiful healing here. When you treat that gap very conservatively, without a flap, and then use a good biomaterial to regrow the bone that's here in the defect.
Robert.
And now we look at the percentage of buttock bone. Look at it in three-dimensional relief. Look how much more dense the bone is than it is in the apical area. The apical area was completely in bone. The wider area here, that was where the defect was. And we get a better quality of bone if we use the correct graft material that has a better biologic consequence.
Robert, excuse me.
So we talk now about hydrating graft materials. We talk about perhaps hydrating them instead of with anesthetic solution, instead of saline, and instead of using whole blood. The reason why I no longer use whole blood in a lot of my grafting is that when red blood cells break down, they become acidic. And when in an acidic environment, you completely shut down the osteoblast. The osteoblast will not produce bone, or will not produce type 1 human collagen until the pH goes back to normal. When I use autologous serum or I use autologous plasma, we get a much, much better result. But here's posterior right mandible. A ramped ridge. The entire facial complex is gone. The facial incisal line angle. And a tiny little knife edge ridge here on the lingual side. And just basal bone, no bleeding. So we're going to place a few tenting screws. This is just to maintain the volume, maintain the space for our graft material, because one wall defect like this, it's going to be a while before we re-enter this. And these are placed about 5 millimeters off the bone. And the head of these screws are going to be placed right where I want the outer portion of my bone to be. So they're placed strategically. Then we decorticate the bone. You can see it's placed 5 millimeters off of the bone. Now this time, however, we're placing the bone graft hydrated in autologous material, covered by a collagen membrane. In a one-wall defect, I need more space maintenance. But the last layer in this case is going to be a pure-off membrane. So I've mixed my graft material with autologous fibrin and autologous growth factors. I've used an occlusive collagen membrane. However, the last part was a PRF membrane because I want the contribution from the periosteal side. The only way I can do that is to use a material that will encourage the undifferentiated periosteal stem cells to become osteogenic cells while the collagen membrane is resorbing over time. Get a good periosteal release, get good primary closure of this.
Robert.
And this is the reentry. In this case, I waited 6 months because in a one-wall defect where I have a lot of bone to regrow, I want the best possible outcome. I don't want to go in there prematurely with soft bone. Look at the bone. This is the original ridge back here. All of this is grafted area with a good cortical zone. I've got a 12 millimeter wide ridge now. Now I'm going to go ahead and remove the tenting screws. And the tenting screws you will see here, look at the vascularity of that bone. This was formerly air, space, just graft material.
Hello, Robert.
The bleeding from inside here. That's what I want. Now I'm going to go ahead and drill my osteotomies. This is a 6 millimeter wide drill with 3 millimeters of bone on either side of it. And as I'm drilling, I remove it, and you will see the vascularity of the grafted bone. Not like that first case I showed you, which was all graft material, no vascularity. This is 100% vital bone. When I remove this, look at the bleeding already. This is after the implants were uncovered, the healing abutments placed. Look at the quality of the tissue, the thickness of the tissue. Look at the amount of keratinized tissue that's here. This is a 1 year post-op on this case, showing beautiful retention of form and width and keratinized tissue zone. But you don't realize that this tooth and this tooth are also implants. The reason I'm going to show you this is the following. This is a post-op radiograph of the completed case prosthetically. These two implants here were placed extraction, immediate implant placement. And when we do that and have a good implant system, you get some pretty decent density of the bone surrounding it. And that's what I want to see, some pretty nice trabeculation. However, in the site where we grafted first and then went into place or implant, look at this. Look at the density of the bone right here. This is not graft material. There's no graft material left. This is the density of bone. So in this case, when you use the right material with the right growth factors, you can actually end up with bone that's more dense than the original bone that was extraction immediate implant placement. This is what I prefer to see. This is 75% vital bone, as opposed to 45 to 55% that we get in when we use something like an allograft.
Excuse me, Robert.
Yes.
I'm fine. You weren't hearing me. I was trying to.
I had my speaker off for a second.
Oh, okay. I'm sorry. We have two questions here from Dr. Jeffrey Krantz. Can you read them on your screen there?
I don't see any questions here. You have to read them to me.
Okay. He asked, in this case placed by the Floridian periodontist and the buccal defect, what were the clinical symptoms? Because the video showed a healing cap. How did you know it was failing?
On which case now?
The one, the Floridian periodontist.
Oh, that, well,
a few minutes ago,
Florida periodontist was the one where he did the 2 sinus grafts.
That's correct.
That and because when we look at this radiographically, that was the implants were not placed yet in those sinuses, so nothing failed there. But I think he's referring to one that was done earlier. How do we know when it's failing?
The question was at 12:48, about 8 minutes ago.
Yeah, that was an earlier case. Well, there's going to be mobility of the implant. There'll be pain on function. There'll be pocketing around the implant. There'll be a red ring of tissue. Sometimes when you press on it, there'll be a little bit of suppuration. I mean, there's a whole host of symptoms that you will see showing you that there's a complication or a failure there. We don't go into, if there's no pocketing, no erythema, no edema, then we consider that to be a healthy implant. But once you start to see the sequelae of a complication, that complication then just leads to other ones. So there's specific symptoms that we're looking for.
The other question Dr. Krantz has is, he says, with the lower mandible and screws, why no PRF membrane?
With the graft that we did on the lower mandible?
I think that's what he's referring to.
Yeah, there was a PRF membrane. The final layer was a PRF membrane over the collagen membrane in that case. And that's important, because even if I left out, and sometimes I will leave out a final PRF membrane, but if I do that, I will hydrate my collagen membrane in either autologous serum or, better yet, autologous plasma, because that gives me the same growth factors that I would have if I were to use PRF as my final layer. So I'm actually accomplishing the same thing, even though I'm leaving out the final PRF membrane. If I weren't going to hydrate that at all, or be whole blood or saline to hydrate my collagen membrane, then I would need and I would use a final PRF membrane. But I always hydrate my collagen in autologous growth factors because I want to make them bioactive. So there's always a component of autologous growth factors in every case that I do. All right.
Okay, let's move on.
Okay. So we talk about composite grafts. I mean, the whole idea of this lecture then was to do a lecture on composite grafting. The ability to use an older type of graft material in particulate form, but use it with a different carrier, which mitigates out some of the problems that we have, either in handling or in placement or the biologic response. And that is why I use this particular type of material. Now, I've actually been using OsseoGen products for over 25 years. When I was in my training, and I was trained by an oral and maxillofacial surgeon at that time, 25 years ago in my program. And he was using OsteoGen particulate that we then mixed with a capsule of tetracycline. So if you look at my photographs, my 35mm slides that I was taking pictures of back in that time, all of my bone grafts at that time looked yellow because they were all mixed with tetracycline paste. But that's before the concept of composite grafts. First, it was just the graft by itself with venous blood. Then in sinuses, we had a number of infections post-operatively in our sinus grafts. So we decided, well, then there's obviously some bugs in the sinus. Let's use a broader spectrum antibiotic, which is what tetracycline is, and mix it with a bone graft material and have success. And it actually did work. But there was still the problem of using a particular graft material. And then we went on to use other materials, the tissue bank bone, and then the xenografts. I mean, every kind of alloplast, every kind of material you can imagine, with and without antibiotics, with and without growth factors. And finally, when we were working with this material, which I stopped using because so many other products were introduced into our program and then into my private practice, I just got away from it. I never had any problem with it. It's just that it was, for me, it was just another particulate material. Now, OsteoGen is a very unique biomaterial because it's highly resorbable, means that over a period of time, virtually all of it is resorbed and replaced by bone. That is what I want. I don't want residual bone graft material. I want host bone. The only exception to that is in a non-loaded area of my ridge where I don't want resorption of the ridge at all, where the intaglio surface, either a pontic or the intaglio surface of a FP3 prosthesis would be. Now, they make an OsteoGen highly sintered product that you can crush up. They come in pellet form, you can crush up in a bone mill, and it has more of the behavior of a cortical cancellous bone graft or even a xenograft. It takes a long time for it to resorb. So I will use that material, for example, in my pontic areas. It is hydrophilic. It takes up a fluid, especially blood and serum and plasma, beautifully, unlike DFDB. It's replaced by autogenous bone at a rapid rate, meaning essentially the bone graft is resorbed at virtually the same rate as autogenous bone is being laid down, which is a great thing. But here's something that you don't take into account. Many of you don't understand. It releases something called free ionic calcium. Now, we talk about the difference between a bone graft material that's osteoconductive and osteoinductive. An osteoconductive bone graft is basically a scaffold. Whatever material you put in there, the bone cells just grow up and around it. And as they do so, they release not bone, they actually produce collagen, type 3 human collagen, which gets converted to type 1 human collagen. That collagen then undergoes a precipitation reaction external to the cell, to the osteoblast. That is what produces bone. So anything that contains collagen can mimic the action of an osteoblast. That's a good thing. I want a collagen-containing material. That's why we use freeze-dried bone or demineralized bone, because it leaves the collagen present. But one other thing occurs, that is when you have calcium being released by your bone graft material, the calcium is a trigger to an osteoblast to start producing collagen. So that's what makes it not osteoconductive, it makes it osteoinductive. What is the definition of osteoinductivity? One thing and one thing only. That's the ability of a material to grow bone ectopically. What does that mean? It means that if you were to take the classic model for osteoinductivity, you took a material, put it into an animal study in muscle, not in bone, and then you went back in with that material in a few weeks or a few months, looked at it under the microscope. If bone grew around that material outside of bone, in this case in muscle, that material is deemed to be osteoinductive because it helped convert undifferentiated stem cells in the bloodstream to bone producing or osteogenic cells. That is what I want. I want to use a material that is in fact not just conductive, but inductive as well. That's why it's so important to have materials that rest against periosteum, because periosteum also has undifferentiated periosteal stem cells, which can convert to osteogenic cells. So I want a good osteoinductive material. That's what Osteogen is.
Robert, we have another question from
Yes.
Dr. Krantz.
Yes.
He says, he's asking, what would the advantages or disadvantages be of the Osteogen material versus the ground tooth material?
Okay. Dentin, you're talking about dentin autograft, and I use that in my practice. And a dentin autograft is used, for example, I don't have it. I probably should have put it in this presentation. If I'm taking out a tooth, I can use the dentin material because it's non-resorbable. So I can use dentin material in a taglio surface of a hybrid prosthesis. I can use it under a pontic. I can also use it in the gap between my facial plate and my implant. And the reason for that is you do not get a multinucleated giant cell attack on dentinal particles, because dentinal particles are recognized as a part of the host. They're not foreign bodies. You don't get a foreign body reaction. And the bone literally goes around it. Dentin also contains growth factors. So the body is recognizing it as part of their own. So I'm afraid, and I'm going to show you actually some radiographs, some videos where we've lost facial plates around implants. And because once you place an implant, there's no stimulation by a tooth through a periodontal ligament, facial plates, if they're very thin, will resorb, they'll get lost. So dentinal autografts are actually a beautiful thing. Problem is, I can't always harvest a tooth and then use that in my dentin grinder. You have to be very selective. If it has big silver fillings and stuff, you have to cut away that portion of a tooth. If a tooth has been endodontically treated, you can't use that tooth. Only fresh teeth, and you cut away the diseased portion of the root and just get fresh dentin underneath there and then treat it with the Composite Bio protocol. But dental autografts are actually very, very good, and I use them occasionally. You get a higher stress-bearing modulus because of the increased density of bone that we showed you from the previous posterior case. There's no foreign body reaction, even if exposed before it's incorporated into bone, because calcium-releasing bone graft materials are also bacteriostatic. And we've known about the bacteriostatic function of calcium for decades. Back in the 1960s, 1970s, we were already talking about that. And we get not repair, we get regeneration. That material turns over, and when it turns over, it becomes host bone. So if I'm going to place an implant in that area, I want host bone, not graft material. And in the chemistry, it is a synthetic resorbable graft. And I guarantee you, it was already a problem using tissue bank bone up until this point in the past 10 or so years, because we had some very, very bad press. You might remember a story about an oral surgeon in the New York area who's now in jail. I think he just died, as a matter of fact. But he was harvesting bone from cadavers and then selling it on the market. So one of your patients might have the bone of Alistair Cook in their body, but people were already hesitant in receiving tissue bank cadaver bone. Now with pandemics, I'm sure that hesitancy is going to be even more profound now than it ever was before. They don't want any possibility of developing some kind of condition or disease based on the condition of the host that donated the tissue. So we're going to start to see more and more synthetic or alloplastic materials being used in implant dentistry. It's got a calcium to phosphate ratio of about 1.5 to 1, which means it's an enormous amount of calcium available in the biology of this. That's what I want. When calcium phosphate dissociates, the amount of calcium that's available for function, that's bioavailable to transform and convert cells into osteogenic cells, is going to depend on how quickly we regenerate a site. You get both solution and cell-mediated resorption, primarily in this case, solution-mediated, because the action of the osteoclast basically just dissolves this. As soon as it comes in contact with fluid, it already dissociates. So it's very easily resorbed by the body. It's a non-ceramic form of hydroxyapatite. And because it's somewhere between tricalcium phosphate and the regular HAs, it's got the best parts of both of them. It's completely resorbable over time, but it stays around just long enough so that it acts more like an allograft. But it's non-ceramic, which means that it ultimately resorbs completely. It's got more purity than ceramic HA. You don't have what we call the amorphous phases of TCP, which actually elicits an inflammatory response beyond which you want. No pyrophosphates as found in HA products, also eliciting an inflammatory response. But the best thing for me as a clinician, as an implant clinician first, and as a biologist second, is that my grafted sites actually show up not like bio-os, not as radiopaque, but rather radiolucent. They start off being darker, and over time, they become more radiopaque. And that is my metric that I use to decide when I'm going to place my implant. And the size and density of the crystals are ideal for the timing and chemistry of resorption. I've pretty much discussed all of this already. Let me see if there's anything I want to continue with this. You get contribution of both collagen and graft. It's hydrophilic. You get absorption of blood in there. You prevent particulate from migrating when you use it in its composite form, which I'll show you in a moment. And you can use it to carry other growth factors, whether it's growth factors that you purchase, what we call recombinant human growth factors, such as GEM21, the PDGF, platelet-derived growth factor, or Medtronic's Infuse, BMPs, bone morphogenic proteins, or you can put autologous serum, or as I do with all of my OsteoGen cases, I use autologous plasma. I'm going to show you a healthy dose of those kinds of cases. Now, this is what a case looks like after extraction of a tooth and placement of an OsteoGen composite graft. In this case, an OsteoGen plug. It's relatively radiolucent. You can see a hint of the graft material, but it's relatively dark as compared to host bone. What happens is, over a couple of months, it starts to look like this. Not only is it getting radiopaque, there's actually trabeculation forming in this. That is my feedback mechanism to determine when I'm ready to place my implant. When it starts to get dense like that and I see a good cortical zone forming over the top, I know I'm ready. And I'm going to show you actually some reentries in video form to show you that. But before these products were present and I was still using Osteogen, I was creating my own composite grafts by combining particulate Osteogen with fibrin, making, you know the name, sticky bone. So I'm going to go ahead. This was a failed implant. I'm going to debride the site. I'm going to mix my Osteogen particulate with my autologous plasma. I'm going to go ahead and debride any kind of material that's left on the implant body, especially if I want to regrow any kind of bone on the adjacent implant. And I love lasers for this. This is a BioLase I+, which is an erbium chromium YSGG laser. Beautiful for not just debriding the surface of an implant, making it surgically clean, but better yet, removing all pathology from these sites, right down to good, healthy bone. Go into the surgical site as well, make sure there's no contaminated tissue, granulation tissue, or bacteria left in the site. Now I'm ready to graft. But the graft is going to be a composite graft, but it's a composite graft that I have made myself. Now, as I carry this graft, you'll note that it's not a particulate form. It's in the form of, well, let's call it sticky bone. Here it is. It started off as particulate, but when you fibrinolyze it, you mix the fibrinogen and then make it coagulate, all the particles stick together. And now you have a bone graft material that you can literally mold into place. At that time, I was even covering it with a collagen membrane because many years ago, I wasn't sure about the durability of something like this. You don't even do this anymore. But this was a pericardium membrane that I was using at that time, and then getting good primary closure over the top of that. And we had beautiful results in terms of volume and quality of bone, because that bone graft material would resorb completely and turn over into host bone. Now, the CEO of Implant, who's a PhD and one of the pioneers in bone grafting products, his name is Maurice Phelan, looked at me one day. I showed him some of my videos that I was doing, and he laughed and he goes, "Robert, you're working too hard." And I said, "What do you mean, Maurice?" And he goes, "I have a product that has already done that for you. I've made a composite graft." It's already put together. Bone graft particles are embedded in collagen, and then you can mix it with whatever material you want and try. Tell me, you want to give you some, tell me what your clinical outcomes are. So in that case, we were just adding growth factors, and I'll go through this quickly. We were going to spin these white tubes that didn't turn into a fibrin clot yet. They had no clot activator. We spin them for about 3 minutes. And while it was still in liquid form, we would go down into this bright red zone, which is where the platelets are, draw off all of the fibrinogen, which is plasma essentially, but no red blood cells, just the bright red part. Then we would bring it to our graft particles, that sort of tannish color, the pinkish tannish color. That color is from the platelets, not from the red blood cells. And I would hydrate this material, put it on the side for about 20 minutes, and it would auto-coagulate over time and form a PRF membrane within the material. So I already had a composite graft. I had it in the form of a collagen plug that had Osteogen crystals embedded in it. And then I added this cocktail, which in this case was autologous plasma, and used a composite graft consisting of collagen, Osteogen, and plasma, which formed a PRF membrane. So we can add antibiotics if we want, a few drops of metronidazole, but the ideal fluid is either autologous serum from the bottom of your collection box, or better yet, autologous plasma, because it becomes a PRF membrane within that. Now, just a few slides on autologous growth factors. The growth factors are essentially polypeptide proteins that do several things. They either inhibit or encourage cells to proliferate, to grow, or cells to differentiate. If we want to take cells that are undifferentiated stem cells and make them osteogenic cells, we can add this material. We can attract cells. It's called chemotaxis. We can make cells come to the area where we want these. We can make cells stick to the site. That's adhesion. Or, just as importantly, we can regulate gene expression. What that means is if we have an osteoblast already producing collagen that will ultimately become bone, if I upregulate the metabolism of that cell and produce more collagen, I'll get more bone more quickly. It's present in platelets, white blood cells, circulating blood, and it improves the healing of everything. Now, the reason we use autologous plasma is that it contains literally hundreds of growth factors. And these are just some examples of the important ones for us that we've studied in detail. But you'll note that every one of these early steps in the healing process is not a singular phenomenon. It's not just one growth factor. It's always a group of these growth factors together. So if we want fibroblast migration, we'd always talk about platelet-derived growth factor. Yeah, it's an important part of fibroblast migration, but it's also epithelial growth factor, fibroblast growth factor, transforming growth factor beta, tumor necrosing factor, and interleukin-1. Oops, let me go back here. So all of these factors together are responsible for fibroblast migration. And the same for proliferation, the rudimentary blood supply, initial vascularity. It's not just vascular endothelial growth factor, it's other things as well. Collagen synthesis, transforming growth factor beta, which is a form of BMP, and platelet-derived growth factor. That's why we use autologous growth factors, and that is why I use plasma and not just the serum. I want all the cells that will produce every one of these growth factors. So platelet-derived, platelet-rich, leukocyte-containing platelet-rich fibrin is a second-generation material that when we undergo a polymerization of converting fibrinogen to fibrin, it actually looks like this. Circulating fibrinogen polymerizes and traps these cells. These cells then remain viable for 7, 14, up to perhaps 21 days and continue to release their growth factors over that period of time, which is a great thing. Because without them, a lot of events that occur within the first few hours or days, they're finished. They don't contribute to anything farther down the line. Bone growth doesn't begin until 7 to 14 days. So unless you have live cells pumping out these growth factors at 7 to 14 days, you really haven't contributed that much. But PRF does that for us. Now, when we talk about our composite grafts, which come in many different forms, and I'll show you several of them. This, of course, is the most widely used. We call Osteogen plugs. They're Osteogen plugs. They have an embedded graft material, Osteogen, inside them. And then this is bovine Achilles tendon, type 1 bovine Achilles tendon that holds together the complex. It comes in a very narrow form, comes in a wide form, and just in the past month or so, it came in the super wide form, which is about 30% larger than this one. I just used one yesterday. I took out this massively big molar, mandibular molar, and even this plug, the wide one, would not have been enough. So I used the super wide one, cut it in half in the bottom, in the apical portion, and put the one plug with the 2 individual roots, which we'll share with you in a video. This is what we want. And then, of course, we have one more side, which is super large right here. But this is what we want. Type 1 bovine Achilles tendon as a carrier, and the Osteogen non-ceramic material embedded inside there. Now, they also come in tape, they come in strips, they come in a lot of different forms. We'll discuss this. So if we're going to, for example, do an extraction, we're going to extract the site, we extract the tooth, we're going to prepare the site, we're going to curette it, we're going to make sure all the granulation tissue is gone, make sure we have good bleeding points in there because we don't want to put this into something that's not bleeding. Here's an immediate post-op of an extraction. I'm going to go with my curettes. First thing I do is I try to grossly debride the extraction site, which means removal of any large apical disease pathology. Now here you can see where the apical granuloma was, but the problem here is it's not yet ready for grafting because there's no bleeding from this osteotomy. Now I don't care what instrument you use. I love lasers. Look at me peel away the remnants of the parietal ligament. Go in here, remove the remnants of the apical granuloma, and then de-epithelialize the whole sulcus that's here. So it's going to be really pristine. It's going to be ready. It's going to be decontaminated. All the soft tissue is going to be gone. Now I've got to get some bleeding sites. I don't care whether you use a drill, a round burr, an implant drill. I'm using a piezo surge unit. You can use a laser to do this, but you must do it. You must create bleeding points. Cut through that cortical bone till you start to see these bleeding points, and blood is going in from there. Now, the earlier ways to do this was to put the growth factors from autologous blood into the surgical site with an irrigating syringe. And then I would take the dry Osteogen plug and press it down into the site. And you'd see how quickly the serum or the plasma is adsorbed into the plug itself. You see how quickly that fluid gets absorbed and adsorbed into the plug itself. And then we simply compress this down and concentrate the particles. We just want this to be below the tissue line. I don't care where the bone level is. It just needs to be several millimeters below the tissue because those epithelial cells must grow across. It's going to be an occlusive collagen barrier, even though it's built into the plug. But you have to have space for the cells to go across right here. If it was too high, the cells would never close over the top of this. And then a simple horizontal mattress suture over the top of this. Why? We just want to keep the plug from extravasating. We don't need a collagen membrane. We don't need a PRF membrane because that's a PRF membrane that's built into this. That's it. Our grafting is now complete. A lot of people will just use whole blood inside there. That's acceptable. I find that if I'm using serum or better yet, plasma, I actually get a better result. We can use this to manage sites with facial plate loss because there's a good body to this. The collagen matrix helps to prevent the collapse of ridge architecture. Now, you can't use it without some other tenting device on a one-wall defect, like I showed you in the posterior mandible. There's just not enough body to that to help prevent pressure of the outer epithelium. But it prevents epithelial invasion, prevents food impaction, prevents percolation of saliva into that site. Talk about socket preservation. I had just done this onlay graft here. I took a final radiograph only to find out that there was a lesion on the mesial of this tooth. It was fractured. So I extracted this tooth at a subsequent appointment. And here again, we're going to remove all the pathology down here. You can see an apical granuloma coming out. Do this by hand. It's much easier to do it. You can see all the bone loss from the fracture. And then debride this by whatever means you can. Round burrs, round diamonds, piezo surgery units, lasers. This is the I+ from BioLase. And once we've done that, we're ready for our graft. What is our graft material in here? After we've debrided and decorticated, an Osteogen plug hydrated with autologous plasma. Okay, I'm de-epithelializing the inside of the sulcus. Any red tissue needs to go because that's where all the pathogens are. That's what's going to elicit a postoperative inflammatory response. keep the saliva from going down inside there. But this time I hydrated the plug externally and then placed the plug in situ. So it's already is hydrated with autologous plasma. And now I'm going to take my bone plugger and literally compact this down. You cannot overpack this because you cannot overpack collagen. If it was basic graft material, you could potentially overpack this, but you're not going to overpack this with a collagen-based graft material. See the saliva? The saliva can't get in here now because it's a PRF membrane inside this. Again, we do the exact same thing. We put it down below the tissue level. We do a single horizontal mattress suture over the top of this.
Robert, we have another question from Dr.
Go ahead.
Krantz.
Yes.
He says, PRF membranes are known to be bacteriostatic. Does the plug have that same characteristic?
Absolutely. Absolutely. The plug by itself, just, for several reasons. It contains a calcium releasing material. The calcium release from the Osteogenic is bacteriostatic. But if you're going to use, the collagen acts just like a collagen membrane, especially if there's bleeding internally. And third, if you're mixing with autologous growth factors, especially autologous plasma, it's a PRF membrane that's now incorporated within the collagen plug. So you say, well, why not use a collagen membrane over the outer port? It's already a PRF membrane that's embedded here. So all you do is suture over the top of this, and this is not permeable to saliva, and it's cell occlusive to the epithelial cells that will grow across this. Now, the next video.
Question here.
Yes.
What happens if they don't have PRF?
Well, whole blood then. Whole blood will end up giving you the same thing. Now, there's a caveat with that. And that caveat is the following. If you extract a tooth and you're not going to place a bone graft, what do you put in the patient's mouth? You put gauze in the patient's mouth. And you say to the patient, do what? For the next half hour, you bite down and do not take this out. Why are we doing that? Because we're waiting for the red blood cells that the bleeding into the site to coagulate into a fibrin clot. But it can take up to a half hour for the red blood cell coagulum to really coagulate into a fibrin clot. So we have to protect it by using gauze when the patient bites down. This is already coagulated prior to placement. So if you're not using PRF and using just the patient's blood from the decorticated bone, make sure you do not have salivary contamination of that for the first 10, 15 minutes while that fibrin clot is maturing. How do we do that? Well, we keep the site open for a few minutes and not allowing the saliva to leach onto the surgical site. And then we put some gauze on the top of that and let the patient bite down. So we limit the effect of saliva on that. So that's what you do if you're not using PRF. Let me go back. Go ahead. Go ahead.
A follow-up question from Dr. Krantz. If that is the case, the bacteriostatic component, why is the lasering removal of all pathogens that important? Wouldn't the plug do that for you?
If you do not remove gross granulation tissue at the bottom, you can still potentially get an infection. And I don't care. That's why I said the first thing we do is we hand curette it. We go down with surgical curettes. We take that out, use a piezo search unit, irrigate it with saline with some aqueous metronidazole. Just need to do it. Take some round burrs and remove the soft tissue and the peroneal ligament that way. There's a number of ways that you can do this. I just find that the most effective, most efficient way to debride an osteotomy is through the use of a laser. And I've had lasers for 23 years. I've had that wavelength. So that's my go-to instrument. If you don't have it, then you have to use ancillary instrumentation. but you need to have those. Very large round burrs, piezo surgery. I don't care what you do, but remove all traces of soft tissue. That's paramount. Then remove any of the layer of the lamina dura that's there and decorticate that, and you are basically good to go. It takes longer. That's a little bit more effort on your part, but that's what you need to do.
We have another question from Dr.
Yes.
Jose Luis de la Garza. If my memory is correct, he's from Mexico.
Okay.
If you have vestibular tablet lost, can you fix that with the OsseoDent plug?
The vestibular depth, are you talking about?
He says vestibular table. I'm sure that he's referring to.
I think he's talking about, I hope he's talking about vestibular depth. If you want to apically position a flap, you can do that, but basically you're not going to really get that much contribution to vestibular depth from that. One thing I like about doing the technique this way is that you don't have to coronally position your flap to get primary closure over this. When you coronally position a flap, you're actually moving your mucogingival junction coronally. That's reducing vestibular depth. And now you have to worry about the amount of keratinized tissue that you have post-operatively. So the reason I love this kind of grafting is I do not need primary closure when I use these kinds of composite grafts. All right, now this is a 1 week post-op on that case. That large open area that was here, look at the rapid epithelialization of that opening. That's what I want at 1 week. When I see that, I'm all smiles because I know I'm not going to have a complication. That graft material is inside there. It's completely covered. Look at the quality, look at the thickness of the tissue at only 7 days. Implant placement in a regenerated ridge. Now, what do we know? We want to see what these ridges look like when we re-enter them. Well, I used to go 4 months in these cases. I now go 3 months. Here's a 12 millimeter wide ridge, good keratinized zone because the mucogingival junction was not moved coronally. And when I open these, because I've been using a lot of different graft materials over 35 years, I was always concerned about having a lot of particulate material left. You see just a couple of little crystals left right here, but otherwise, look at that bone. The quality of the bone.
Robert, we have a clarification.
Yes.
Of the previous question about the
Let me stop right here then. Go ahead.
Herman Murias, I think you know him well. He says that the doctor's talking about the buffalo wall.
The buckle plate?
Yeah, he said here buffalo wall. I'm sure he means the buckle wall.
The buckle wall.
Yeah, and then
yes, if the buckle wall is gone, if it's, for example, a Miller type 1 or a Miller type 2 case where there's still wings of bone here and here, the OsseoGen plug alone is sufficient without using anything else. I can regenerate this missing plate. I will actually show you how, if it's a Miller type 3 defect or beyond, or dramatic loss of bone, how we use a different kind of product to rebuild this.
So, but basically, another almost identical question. So if there's no buckle plate, is it okay to place the OsseoGen plug?
Yes.
Of course.
Absolutely. But we compress it down so it becomes more dense as you do that. Then it has the percentage of mineral to collagen almost exactly the same as natural bone when we compress it down. And a lot of times early on, what we did was we did the histomorphometry. We'd take core samples, and just to show you that, in fact, these are OsseoGen sites. There's a couple of crystals left here, but look internally when we do these things. Look, it's already stress-bearing lamellar bone forming in these sites at 3 months. And that was even before we started to combine them with autologous materials, autologous plasma. When we do that, We're even in a more advanced stage earlier. OsseoGen bone block for on-leg grafting of one-wall defects. This will speak exactly to the question that was just posed to us. What do we do when the buccal plate is missing, but grossly missing, where there's no wings of bone on the outside? Everything is resorbed to the palatal or to the lingual. What this represents is the fluid portion, the fibrinogen that comes from those white tubes as it's forming what we call a plasmatic membrane. And then we can use that material to hydrate our graft material. In this case, not a plug, not a strip, but an OsseoGen bone block. And the bone blocks are much thicker than that. They're made of the same material. There's a little bit of pliability to them. What I'm doing here now is I'm adding a couple of drops of autologous serum, which helps to coagulate this in 15 to 20 seconds. And now you can see a little bit of cloudiness forming right here. It's still liquid. And as I'm rocking it back and forth, you'll actually see some cloudiness forming as the fibrinogen gets converted to a fibrin clot. Still liquid. Then suddenly it gets more viscous. Start to see a little bit of cloudiness forming right here. That's the polymerization reaction. Look at that. It's not liquid anymore. As I move it around, it's a plasmatic membrane. Look at that. Literally 15 to 20 seconds. Now I'm going to lift I'm going to actually lift the bone block off. And you can see how the plasmatic membrane adheres to the OsseoGen bone block. Look at that. Now it's a plasmatic membrane within the bone block. Now it's still slightly soft and it remains like that. And that allows you to mold it to the site. So here's a case that I did just a couple of months ago. This is a deficient site on the facial. The facial incisal line angle is gone. I'm going to take that bone block, which is pretty thick. I'm going to prep the site. Here it is. The plasmatic membrane is now built into the OsseoGen material, making it a composite bone graft. Collagen, OsseoGen, plus a plasmatic membrane. I'm going to open this up, resorb to the lingual side. I'll decorticate this. And make sure they're critical size defects. There's usually about 2 millimeter size holes in here. So you get good bleeding. And you want to make sure you get good red bleeding. Now I'm taking the block to the site. And then Implant also makes one of the most beautiful screw sets I've ever seen. It's called the TriStar system. And the beautiful thing about it is that they're self-drilling, not self-tapping, which means you don't need to start the osteotomy. You just press the screw right into the site. It drills into even the most dense cortical bone. The upper part of this is not threaded, so it never integrates. But you see, and it's got a square recessed head here, so you don't strip out these screws. It's easy to carry to the site. It's easy to engage the bone. Do another one right here, then mold over the top of it, perhaps put a little bit of particulate material around the sides here. And now you have, in essence, a replacement for corticocancellous block graft. And these screws act as tenting devices, just like the earlier case I showed you. I'm going to mold the block into position. Then we sometimes mortise in a little bit of material around the edges. We go to do a good periosteal release. I'm going to release the periosteum because I want to get primary closure of this. Very simple. You take a fresh blade. Don't use the one you used to make your flap. Brand new one. Very lightly brush until you separate the periosteum right there. Just being careful of any critical structures like the mental bundle. I will put a PRF membrane over the top of that. I love PRF, even though I've incorporated that into my, my block. If I'm drawing blood, I always want some membranes left. If you don't do this, use a collagen membrane hydrated in the serum or plasma, I don't care. Make sure you get good passive closure over the top of that. Here it's sutured. And I always use a combination of interrupted and horizontal mattress sutures. This is what it looks like at 1 week. Beautiful primary closure. And I forgot, I actually have the, not just the post-op reentry, but the post-op of the implant placed in this position. So we're well along in this case. I did this case bilaterally. Sinus grafting. This material can be used in strip form. It can be used to put against your Schneiderian membrane if you have any hint of a perforation, and it's estimated that 30–40% of the time when you do a lateral wall sinus graft, you'll have at least a minor perforation through your membrane. All right, make sure you're going to crest, making sure you're getting from the bottom of the ridge all the way to the medial wall, reflecting that up. Then you go posteriorly, then you go anteriorly, leaving no voids there. Now, the first layer, you see the bellowing as the patient's breathing in and out. First layer, I will use an Osteogen bone strip. And that way, if there is a perforation, a lot of times it's the perforations that you don't see that are the problems. So I'm taking a bone strip, I'm going to place it in here dry, push it right to the medial wall, then push it coronally. And you can see it picking up the blood from the inside of the sinus. Just move it coronally. Now I'm ready to place my particular graft material into my graft site. I can use the Osteogen. I can continue with the Osteogen. I can use Osteogen plug, Osteogen bone strip, Osteogen block. In this case, I made a composite graft using TCP and then placing it here as sticky bone. I'm going to show you the same kind of case. Instead of using TCP, I'm using Osteogen particulate. And we do mix a few drops of aqueous metronidazole in there, and then a final PRF membrane over the outside. These cases heal so beautifully with the highest percentage of vital bone that we get, and they don't become infected because you've mixed it with metronidazole. Final membrane, I don't care whether it's collagen membrane, PRF membrane, but you must exclude any possibility of the fibroblast growing in from the soft tissue side. Another one, a similar kind of case where we're going to go ahead and create another window here. And then we're going to use PRF. And this is using a piezo surgery unit, but a different kind of tip on here. This is called an elephant foot. And the elephant foot is nice because you go and you physically touch the membrane, and the vibration of the tip actually pushes the membrane off of the bone internally. But even then, just cutting the window, you can always have a small perforation. So wherever possible, we'll use the Osteogen. I'm going to just go ahead and peel this back. First, I've gone from the bottom of the osteotomy off the crustal floor first, all the way to the medial wall, and then go anterior and then go posterior. And this is the point at which you're going to tear a membrane if you're doing this. If you've done enough of these, this is the trouble part. Now, there's a perforation right there. I see it. And I say, no, not a problem. I'll just continue reflecting my membrane, making sure not to do any more damage than I've already done. But sometimes, you know, these things can be very, very thin. Again, I'm going to take a Osteogen bone strip, put it in here dry, push it right to the medial wall. And then as I do that, I'm going to push it coronally, and then I know that I have sealed that perforation. All right, then just take your sinus instrument, push up the membrane. You can see a clean medial wall back here, nice bone. It's already absorbing the blood. Now I've used an Osteogen syringe, and I've drawn the serum up into the syringe, so it's wet. I'm going to go ahead and place that right into the grafted site. Just go ahead and push that in so I know it's within the sinus. Then we cover it with a funnel membrane. I don't care whether it's collagen or, in this case, it's going to be an Osteogen bone strip hydrated with some plasma for additional bone growth on the outside of the ridge. Sometimes we need a combination of inlay and onlay graft.
Robert, we have another question here.
Go ahead.
From Dr. Krantz again.
Yes.
Why a dry Osteogen strip? Why not hydrate it to gain full use of its properties? Or
because when it's wet, it has no body left to it. It's harder to push internally. That's why. The only reason. Otherwise, I would do it wet. But it's going to be more difficult to push and making sure I'm getting it to the medial wall. This way, it's got some good stiffness to it, and I know that I'm getting all the way to that medial wall. That's the only reason. So here it is, covering with the final onlay graft of the Osteogen material, getting good primary closure over the top of this. And I know I've got 10 minutes left, so I'm going to just do a few more videos and then get to the point where I can sum this up, even if I don't get to all the videos, and you'll just have to return on another day when we can do some more of this. But here's
by the way, sorry, we have a special guest here. We'll have him say a few words at the very end.
Okay.
Maurice's son, Andrew.
Oh, Andrew. Yeah, I haven't spoken to him in a while because we're not allowed. We haven't been able to go to the conferences there, but I'm looking forward to that. So here it is. I'm going to go ahead and start my osteotomy. This is just a gauge that allows me to place my implant right in the center of the ridge, and then drill down. This is a regenerated ridge, and look at the quality of this bone though. When I'm drilling into it, it's not soft at all. It's pretty dense material. I place my implant here. I place on the healing abutment. I get good initial stability, but on these ramped ridges, sometimes you'll have a little bit of a defect. I'm going to do a little bit of grafting. Here, I'm going to take a small Osteogen bone strip. You see I've cut out a little bit of the area where the healing abutment is. So I'll be able to do like a 3/4 onlay graft, a little bit on the facial and a little bit interproximally.
Excuse me, Robert, we have another question.
Sure.
Dr. Kakmak is asking, can you please explain again very shortly, in the area where we want to apply an implant, what is your preference to bone augmentation in the sinus area? Extracted tooth socket for median implant and vertical and horizontal augmentation.
Well, that's a lot. That's more than one question. That's multiple questions. So
specifically says, I'm not asking to repeat the whole webinar. Just in a few words, please, if you can. Socket graft use, this sinus, I'm having difficulty.
Well, the bottom line is this. In fact, in my conclusion slide, I'll talk a little about that. I want as much vital bone as possible. When I'm doing this material, I'm getting about 75. We've done the histomorphometry. I'm getting about 75% vital bone. That's critical for me because that's the stress-bearing bone. I don't want graft material that's left. I want it to be adaptable. I want it to be responsive. I want it to have a high vascularity. That's why you see a lot of bleeding when we reopen these flaps. Socket preservation. Now, let me ask you a question. can we go a little bit beyond 2 o'clock? Is that possible?
Yes,
Or
of
do we have
course.
to,
No, it's,
okay,
I
then,
mean, like
because
I
I'd
told
like to get, the balance of these. I didn't think I'd have 2 hours worth, but I have more than 2 hours worth. You never know when you're putting this thing together, how much you're going to talk about each one.
I
Right.
told everybody here that you know how I call you affectionately, Encyclopedia Implantica. So
Okay. All right. What do we do? For example, we've extracted a tooth, but we've extracted it non-destructively. I don't call it atraumatic. Every extraction is a traumatic surgery. But if we extract a tooth non-destructively, and we have bone left, we have the septal bone left, the septum in a lower molar, a septum left between the mesiobuccal, distal buccal, and palatal roots in an upper molar. How do we graft that? Do we do 3 small slim plugs? Well, yeah, it gets expensive there. $50 per plug times 3. You're using more material than you thought possible. Or can you use a single plug, actually physically cut it, and then have those portions splayed out into the root forms that you have? I'm going to show you 2 videos here. This is an extraction of a tooth that's a true rooted molar. Here we're going to, and especially endodontically treated decayed teeth like this, you can't possibly extract this in one piece. So we're going to do an extraction, we section it and take it apart as 2 pieces. And I will tell you that endodontically treated teeth like this, you probably know this already, they can be a bear to get out. You spend a lot of time. Sometimes I'll go up, an hour just extracting teeth so I don't destroy bone. Fortunately, this one was not too bad. A lot of times they're ankylosed, but in this case, we were able to get this out without any problem. I did one yesterday. I spent literally almost an hour and a half extracting a lower molar. All right, then the same thing for the distal root, but look at the septal bone here. So I don't want to use 2 plugs. I'll use a single plug, and I'll simply cut it in half so that that single plug will fill both of these sites. Now, again, do the debridement. I don't care. I'll say this over and over again. Get rid of any potential pathology here. Remnants of a tooth, remnants of apical pathology, remnants of the periodontal ligament, any remnants of the sulcus that has periodontal pathogens in it. Use round burrs, use round diamonds, use, in fact, Implant sells a degranulation kit that are very coarse diamonds. Look at the lamina dura here. There's no vascularity here. This is not medullary bone. This is pure lamina dura, dense cortical bone. You must decorticate this prior to placing your graft. Right? All red tissue, gone. All soft tissue, gone. Periodontal ligament, gone. You see medullary bone in the septal zone, but no medullary bone where the roots came out. So you want to decorticate this. So in a moment, we're going to now, once we've prepared this, once we've decorticated it, look at the bleeding now. So I've taken a large plug, but I've cut it in the apical portion into 2 parts. So they'll go around the septum. One will go into the distal root, one will go into the mesial root. And just start it, making sure they're tracking well, and then compress them right down. And in these cases, instead of putting the plasma into the surgical site, which you can do, and then do a dry plug that goes into that, I prefer now to hydrate them prior to placement. I have no problem getting them to go and track well. And then use your bone pluggers and compress them down into the respective roots. And do not be afraid. You cannot overcompress this material. And as I mentioned before, you must be below the tissue level. And that fluid that comes out is just serum. So compress it down below that. Then you do your horizontal mattress suture over the top. And within a few days, that tissue will close over the top of this. And we're done. I'm gonna skip the rest of this. Here's a 3-rooted maxillary molar. And then again, these endodontically treated teeth, they can be very difficult to get out, especially if the roots have curves to them or they're angulated in different positions. So I will, instead of cutting this in 2 parts, I'll cut into 3 parts. Mesiobuccal, distal buccal, and palatal roots separate. That makes it so much easier to remove and less destructive to the bone. Right, just find where the furca is and just follow the furca right up through the body of the tooth. Then you take a little bit of an elevator, make sure that they're all separated. You see all 3 roots are now moving independently. And now it's just a breeze to get these out. In this case, I made a 3-rooted molar. And look at the way it tracks right down into that site after we've done our debridement. Exactly the same way. Again, don't be afraid to compress this down below the tissue volume, then a horizontal mattress suture over the top of this. Skip ahead here, and that's the horizontal mattress suture over the top, and then a little bit of oxygel over the top of that, just to protect it against any function for the first hour or so. On-leg graft for vertical augmentation. Here's a failed implant case.
Hey, Robert, we have another question here.
Yes.
They're asking why not just cut into 3 plus a body portion. I'm not sure what.
Well, you can do that, but the problem is, you're more likely to dislodge a portion of the osteogenic graft if you do it in separate pieces. That's why I like it as one piece. When I do my horizontal mattress suture over the top, usually in an X or railroad ties, because it's one piece, there's no way for that whole piece to come out. If you do it separately, then you have to add additional sutures. I do an X, and then I do railroad ties over the top of that if you have to separate into parts. So, and I do that. Occasionally I'll have to do that. It's good observation. But here I'm doing the smaller osteogen blocks. I'm hydrating them with autologous plasma. In this case, I've already done a free gingival graft and vestibuloplasty. Now look at the osteogen block. Okay, we're going to flap this. So I've got a good band of keratinized tissue from the gingival graft that I did. Good vestibular depth. But there's no bone. I'm literally down to the apex on this adjacent tooth because all the bone was lost here when these implants were lost. Huge intermaxillary defect. And when it resorbs, it resorbs down to basal bone. But look at this. Look at the plasmatic membrane built into these osteogen blocks now. That's what I want. That's my composite graft. And I'll take each one separately. I'm going to decorticate the bone. I'm down to basal bone, non-bleeding bone. This is not vascular until you go through it. Get bleeding points. Now I'm going to take my osteogen blocks, carry it to the site, and I'm going to use the Implant TriStar screws because I said before, they engage beautifully into the handpiece with the screwdriver. They won't fall out like the normal slotted screws do. They're self-drilling. You don't have to worry about where you place your screw. You just put it with firm pressure right on the bone and it self-drills right into the osteotomy. All right, threaded on the apical portion and not the upper portion. And you will not strip out these screws with the heads here. They're beautiful. And now we're going to leave this about the head of the screw, about 8 millimeters off the bone. That's where I want my bone to grow to. All right, so I'm going to stop right there. And the whole upper part of that screw, look how far off the bone. The bone's down here, top of the screw is here, the rest of the block is here. Put a second screw here, and then put the second block posterior to that. Place some additional tenting screws here. All right, my final screws now go into place. Now I'm going to do a periosteal release because I want to, as much as possible, get primary closure over the top of this. You just evert the flap. Make sure you get passive closure. I'll do a final PRF membrane if I have them available. Not that it's necessary, but I'll have it. Might as well use it. Then get a good suture technique over the top of that. All right, I'm just going to show you the end of this now. And this is what it looks like. This is how far off the bone these screws are. And that's the level of my graft right there. And then this is with the final implants placed right into their proper form. Good band of keratinized tissue, good vestibular depth. Periimplantitis. These are the classic cases that I do in my practice every day. My implants placed a number of years ago. Looks healthy, and yet look at the pocketing around here. And no real bleeding or suppuration. So, you know, it's a site that's going downhill slowly, but you don't want to be a spectator in these things. You want to open these things up and treat them. So we'll reflect this back. I'm going to remove the granulation tissue. Now you can see the size of the defect. Always use a curette or scalers first. Don't try to do this with another kind of instrument. You want the gross amount of this granulation tissue to be removed physically. And then you need to treat the surface of the implant. Now there's two ways that you can do this. One, obviously, with a laser. And I love this because it's the kindest to the surface of the implant and to the bone. The other way is with a Profi jet, with either sodium bicarbonate. But the problem with sodium bicarbonate, look at the granulation tissue that's inside here. You just debride the inside of the flap. Just remove all of this. And with the air polisher, but erythritol is recommended. It's kinder to the hard tissue and the soft tissue. And the sodium bicarbonate will actually damage the implant surface. So I'm going to take my laser, debride the surface of these implants. Any of that red granulation tissue down in these pockets, these circumferential pockets, it needs to be removed 100%. So you'll see me go around, remove all the soft tissue, and at the same time decorticate this bone. This is basal bone right here. Then we have to graft this. We graft it with a composite bone graft. This case, it is Osteogen. It's Osteogen particulate. I use this rather than the bone strip because it's easier for me to get into these very small defects inside all the way around the implant. A little harder with a strip material. But now I'm going to pack it three-dimensionally. Do the same thing on the lingual side and mold it right into place. There's the lingual. And then we just readapt the flaps to this. Sometimes we will place a PRF membrane over the outside of it. Depends on the material that we're using. All right, this is closed, good adaptation to the flat margins. And then 1 week later, the case looks like this. I just take out the sutures and these cases heal so beautifully. Look at, there's no redness of this tissue. The only thing we have to be concerned about, especially when we do peri-implantitis treatment, is salivary contamination, because we can't cover these implants. I normally would like to remove the prosthesis, put a cover screw in, and then get closure over the top. I can't do that with these cases. So we have to adapt the sutures to this. But the fact that I've used fibrinolized bone, sticky bone, means that the saliva won't go down into the particulate material. And the particulate material will not extravasate. That's why they heal so beautifully. Another peri-implantitis case. I just did this 2 weeks ago.
Excuse me, Robert. Excuse me.
Yes.
Before you get out, carried on with the new one, we have well, it's 2 questions in one. What kind of laser do you use, and what's the setting of the laser?
This is an erbium chromium YSGG. It's BioLaser Technologies. It's a 2780 nanometer laser, which has long tips that are able to get down into these crypts. I love it. I've been using it for 27 years. I was actually the first purchaser worldwide of this wavelength in 1997, and I've been using that wavelength ever since. But here's a typical kind of case I do. I do peri-implantitis every day in my practice.
Oh,
Granulation.
I interrupted, but your friend Dr. Germán Murias is congratulating you for the excellent
Thanks.
material and presentation.
Thank you. We're not finished yet. But here we're going to go ahead and debride out the granulation tissue first on the inside of the bone. Now next into the bony crypts. All right, so I'm using the laser. Now you can see debrided. And a lot of times what we'll do is we'll use EDTA or some other material to remove the smear layer. Again, this is a particulate, this is a sticky bone made out of Osteogenic particulate. Note that it acts more like a bone strip than particulate because it's all fibrinolized. And we'll go ahead and we'll just pack this material right into the defect. As you mold it, it's so easy to mold. You can't do this with particulate alone. That's why when it has a fibrin component, it's so easy. And if you don't want to do this, if you don't have the capacity to do this, use the bone strips. And do the same thing on the palatal side. And we're at 2 weeks of healing right now. This case is just beautiful. I cover it with a final PRF membrane where I have it. All right. Did not treat the adjacent tooth because the adjacent tooth would need a different, it's not bone loss, it's tissue loss. So I'm going to let this heal, and then what I can do is I can do a subepithelial connective tissue graft across this to build up the tissue on this one. Get good primary closure of this around here, and I did the same thing on the contralateral side, and both sides are healing beautifully. How much longer can we go? Because I think I have much too much information here. Let me make sure I've got this. 100%. Victor, how much longer do you want me to go? Because I can get right to my conclusion slide if you want. I don't hear from him, so he's probably away from his computer. All right, let's continue. This is loss of a facial plate around an implant that I placed immediately in an extraction site and immediately provisionalized with a bridge, 4 implants. The problem here is that in some of these extraction sites, you're going to get resorption of the facial plate. So rather than do it from the crest, because I know if I do it from the crest, what's going to happen is I'm going to lose this crestal position and blunt my papillas. This is called a VISTA approach. Vestibular incision, subperiosteal tunneling access. So I'm going to go ahead, remove this. And I looked at this and I said, wow, this is about one of the worst defects I've seen around an implant, and still no mobility because it's still attached on the palatal side. As long as there's no mobility, and as long as that implant is splinted to the adjacent teeth, I feel like I have a shot because the implant is still within the alveolus. So in this case, I'm going to use my laser, but I'm going to use it not to remove bacteria or biofilm. It's only to remove fibroblasts from the surface of the implant and the surface of the bone. You just see me peeling away that soft tissue. See how easily that material gets removed from the implant threads. Now I'm going to skip ahead here because I'm going to decorticate this now. Again, it's down to basal bone. You want bleeding before you place your graft material. Now I'm going to place the Osteogen bone strips, hydrated in autologous plasma. And I'm going to sort of mortise this in, just graft it right around and push it into place, starting with the apex. And I'm going to skip ahead a couple of spots here. Then on the mesial, then on the distal. Just forming it around the implant. Then on the other side. And when I've finished working all the different line angles, the last one I'm going to do is on the facial. Here's my final facial Osteogen bone strip. I'm going to cover this with a PRF membrane. Here, I just use 2 or 3 sutures to close off that vertical incision. And basically, that's it. You can literally take off these sutures within 48 hours. A little bit of oxygel to protect the surgical site. Socket preservation. This is going to be the last case I'm going to show you, then we'll end this webinar. This is the typical kind of case I do in my practice. Failing endodontically treated teeth. This is a vertical fracture. And no treatment is going to fix this. We're going to hydrate the Osteogen plug. Again, that pink tinge here are the platelets. I want the growth factors as much as possible. So this is a wide Osteogen plug. And then you just super saturate it. And this is the plastic carrier that it comes in. Super saturate until the entire well fills with plasma and spills out into this indented side right here. Then you know you've got enough plasma within that. So keep filling it, keep filling it. As soon as it spills over, good, you're done. You've got enough in there. Now we're going to carry it to our site. We're going to extract the tooth, and I'm going to skip ahead here a little bit. We are going to debride the site. In this case, I did just as the doctor had suggested. Why not put it into 2 different parts? Yeah, you can do that. Making sure that you're getting it down into each site, compressing it first into the distal site, compressing it down to the mesial site, doing your horizontal mattress suture. I'm just skipping ahead here. Horizontal mattress suture over the top. Okay, over the top like this. Sometimes I'll do 2 extra sutures on the railroad ties to keep it from moving coronally. This is a 1-week post-op on this case. Look at the quality of the tissue, the thickness, the amount, the color at 1 week. 2 more days, it's completely closed off, and I can remove the suture right now. It's a beautiful thing when you see it 1 week. This is the immediate post-op. You can actually see the Osteogen graft up to here. And that's what it looks like. It looks radiolucent. This is the 1 month post-op. Look how it's densifying inside here 1 month. It's just starting to form a crestal portion. This is a 3-month post-op. No collapse of the crest. And we're reforming the crestal component. At this point, I look at it. It's got good density to it. At 3 months, I'm ready to place my implant. What happens when we reopen this? It's a 12 millimeter wide ridge right now. I'm going to skip ahead here because I'm going to drill the osteotomy. Look at this. I'm reopening. Look at the quality, the quantity of that bone. Look at the vascularity. When I drill through it, look at the bleeding from this. That's got the highest percentage of vital bone. I take my wide diameter implant. This is a 6.5 from Intralock, of course, before it got sold to BioHorizons. And you just drill it into place. It torques beautifully in these cases. I get such good initial stability that I put a healing abutment on here, and then a circumferential PRF membrane over the top. I'll just go through this quickly, and just pushing underneath the flaps. These cases heal so beautifully. Now, this is the immediate post-op. Now I'm going to show you the case fully restored. This is with the crown placed. Look, additional bone grew coronally because the last layer was PRF. This is the original bone level at the time I placed my implant. And the bone actually grew up over the shoulder of this implant on both sides. Look at the quality of this bone now. It's already loaded. This is what I'm trying to achieve now. So I'm getting the best clinical results I've ever been able to achieve in 35 years of bone grafting. Conclusions: composite grafts certainly facilitate the grafting process. They make it so much easier to graft a site. They certainly help to maintain ridge architecture. You saw huge ridges after reentry in these things, no collapse. They resorb at the same time that autologous bone is produced. They eliminate the need for any kind of membrane coverage because when you use autologous plasma, it's got an embedded PRF membrane within the graft material. We achieve ideal bone mineralization and density in the least amount of time, up to 75% vital bone. Do not use, however, chlorhexidine if you have this material exposed before it epithelializes. Do not use chlorhexidine or any other commercial mouth rinse, or you will delay healing. You delay the fibroblast growth over the top of this. Just warm saline rinses. Once it's closed, you can go back to chlorhexidine. They're cost effective, they're easy to handle, and easy to place and suture in situ. When you go back in, you will be amazed at the results that you get. So we went we made a 2-hour webinar into 2.5 hours. So I hope you don't mind the fact that we went a little bit over. I'm giving you my email address here. If you want to contact me for any reason, if you have additional questions after that. Victor, did Andrew want to say a few words?
Yep, let me unmute him.
Okay.
Hi, everybody. Can you hear me?
Hey, hi, Andrew. How are you?
Hey, good.
So nice to see you in person.
I just wanted to say I'm Andrew Bound with Implant Unlimited. We're the manufacturers of the OsseoDent plugs and strips. I joined as a participant like everyone else, but Victor asked me to say a few quick words about the current situation, especially given that we are based in New York City. I just want to let everyone know we're open. We're continuing to develop and manufacture the products as well as provide technical support on our normal schedule. I know that many doctors are gearing up to return to a full schedule here soon in the near future. And we just wanted to provide some assurances that, we'll be there when you're ready to go, and as well as our grafts.
Okay, so thank you so much, Andrew. And say hello to your dad.
I will. I always do.
All right, thank you. Well, Robert, thank you so much for all of this.
Pleasure, as always.
Yeah, the other thing I would like to mention, we're going to be setting up a WhatsApp group based on the use of the OsseoDent plugs, where you doctors can ask each other questions, share your cases, and ask each other questions. So we'll be setting that up over the weekend, and I'll send out the links for you guys to register on it. And let's, as all of these WhatsApp chat groups, let's try to keep it on target and just keep it to, the OsseoGen plug or OsseoDent products, type of products. And so that way nobody gets fed up with too many messages, okay? And once again, everybody, thank you so much for participating. For me, it's really an honor to be able to have Robert do something like this for us. And just keep safe and happy Corona to everybody.
Hi, guys. Thanks for the opportunity, and looking forward to meeting you all in person in the next couple of months. So this has to change. So stay safe and open up in a very cogent way, carefully, and we'll all get back to normal within no time at all. Thank you.